Okay. Yeah. Hi, Andrew.
Hi.
Okay. So I'm just going to introduce you and then give the floor to you. So welcome back, everybody, from the break. And today we're talking about social justice and health in February, whose theme is uh, data science and social justice this year. And today we have Andrew from the School of Public Health at Brown, and he's going to be talking about misclassifying race and ethnicity in his work. So welcome, Andrew, and take it away.
Yeah, of course. So first of all, thanks again for organizing. Thanks for inviting me. I'm just down the hill in the School of Public Health. So this is some of the work that I've done with David Myers, and stuff that we're trying to kind of disseminate and publish. So any questions or feedback, definitely very welcome. So I'll just kind of get started. So a couple of things we'll talk about today. So I want to introduce the topic of why race and ethnicity classification is used in policymaking, especially healthcare policymaking. How race and ethnicity is defined collected by Medicare. So for the non-Americans in the room, Medicare is the federal public health insurance system in the US. So for older adults in the US, so if you're 65 and older, you're eligible, or if you're eligible by disability, you're most likely enrolled in Medicare. There's actually two variables for race and ethnicity in Medicare. One's called the Medicare Enrollment Database. I'll get kind of more in detail about what that is, but I'll refer to it as the EDB race code. And then there's a second one, which is called the RTI race code, which I'll describe a little bit in the next few slides. Then I'll talk about the validation study that we did, so our aims, our results, our limitations, and then hopefully I want to tie it back to the theme of the talks about social justice and health, and what are some of the implications of the using race and ethnicity data for Medicare for health disparities research. And hopefully there'll be time for questions. So chances are, if you lived in the US for a while, you're asked for your race and ethnicity in many scenarios. So maybe you're offered a census form, right? And you're asked to mark your race or ethnicity, check off some boxes. It actually turns out if the U.S. Customs and Immigration Services, when you're in the process of naturalizing as a citizen, they ask you also for your ethnicity and race. And then even maybe more recently, when you're signing up for a COVID test with the Rhode Island Department of Health, there's also an ask for your race and ethnicity. And the reason for that is there is an intended use in policymaking, right? There's this idea that it's important for measuring equity. So this time last year, there was this concern with the rollout of the vaccines in the U.S. that certain racial ethnic groups like Black and Latino Americans were receiving the vaccine at a much lower rate than, say, folks in the white race and ethnicity. And there's a concern that states were reporting race data, and that without this kind of race and ethnicity data, we wouldn't have any information on the equity of access to vaccines. And this is relevant even for health disparities research in Medicare. So Medicare being the largest health insurer for older adults in America, it's important source of data for understanding how older adults in America get access to care and their quality of care. So many questions about equitable access or outcomes, they rely on the data in the Medicare, what's called the Master Beneficiary Summary File, or MBSF. And so this was one of the seminal papers about kind of racial and ethnic disparities and outcomes among Medicare Advantage enrollees. So for example, looking at like hypertension, cardiovascular disease, diabetes, and stratifying by race or ethnic group, and you'll see sort of just patterns. But what I really want to point out here is that they use the data from Medicare to get these race or ethnic classifications. So it kind of naturally, the natural question that follows is how does Medicare collect race and ethnicity data? And it turns out it's not what you think. Instead of collecting race and ethnicity upon enrollment into Medicare, they actually use data from the Social Security Administration enrollment, which is another governmental kind of assistance program in the United States. And prior to 1980, the SSA, the Social Security Administration application form, they only had 3 race options: white, black, or other. And in 1980, these 3 categories are expanded to 5. And the beauty of the internet is that you can go back, you can find kind of scanned copies of these paper forms. And these were the 5 categories that were used after 1980, right? So Asian American Pacific Islander, Hispanic, non-Hispanic Black, North American Indian or Alaska Native, and then non-Hispanic white. So there was this problem, right? They started out with these 3 categories: white, black, other. Then the SSA changed it to 5 categories, and so there's this concern, like how do we kind of follow along in the granularity of this collecting this race ethnicity data? So in 1994, it took about 14 years. CMS, which was then the Healthcare Financing Administration, they took 2 steps to revise the EDB race code, the Enrollment Database Race Code. So they updated it from 3 categories to 5. And then they mailed questionnaires to everyone that they were classified as other or unknown to get their race and ethnicity information back. And however, even after those 2 steps, there's still kind of this concern that there was undercounting among the new racial ethnic classification. So a study that was done in 2000 using survey data from 1997 found that even after they expanded the 3 categories into the 5 categories down below, there was significant differences in the sensitivity of the agreement of the variable in the enrollment database among Hispanic, Asian Pacific Islander, and American Indian beneficiaries. So sensitivity being, for example, among those who are sort of self-reported Hispanic, the variable was correct for 39% of them, right? So kind of one way they tried to improve upon the performance of the variable was to impute the race ethnicity of those who were maybe missing or other in the past. So in 2008, Eckeldinger and Bonito from Research Triangle Institute, that's where the RTI acronym comes from, they try to predict in order to indirectly identify Medicare beneficiary race ethnicity using a combination of, and you can kind of find this from the original paper, they use last names from the 1990-2000 US Census. They use first names from, quote, compiled from multiple websites, self-reported race ethnicity from 2000-2002 survey data, which the CAP survey data we'll talk about a little bit more later, and then existing race ethnicity and language information from the enrollment database. So using these and geographic state from the mailing address, using these combinations of variables, tried to predict the beneficiary's race or ethnicity. And this is what we call usually in the file the RTI race code. It's unclear actually how often they update or validate either the imputation algorithm or the race code of the Medicare files, which is kind of the primary motivation for the validation study, which I'll describe later in this talk. So previous work have tried to validate both the enrollment database code as well as against self-reported race ethnicity from 2010, and they found self-reported Hispanics, Asians, Native Hawaiian, or other Pacific Islanders, and American Indians, Alaskanese were kind of similarly under-identified. Sensitivities well below 41, 60, 39, 57% respectively. There was a more recent study that used self-reported race ethnicity from home healthcare visits. So these are folks coming in to provide care at your home, and a collected race ethnicity data from those visits. And similarly, still find kind of lower sensitivities for both the enrollment database as well as the RTI race imputed codes among Asian American Pacific Islanders, Hispanics, and American Indians and Alaskan Natives. But however, because this is like a home healthcare assessment, it's unclear if this race is actually self-reported or is interpreted by the health aide. And it's also, this analysis was only limited to beneficiaries with only a single race ethnicity recorded. So that kind of was the motivation behind the work that Dave and I have been doing over the last year. So we wanted to measure the classification performance of that RTI race variable. And because the problems with the validity of the enrollment database variable was already well established, we wanted to focus on the RTI one. And then we wanted to use kind of a larger set of self-reported race survey data. So we are going to use surveys from what's called CAPS and HOS from 2015 and 2017. And we wanted to evaluate how well the RTI race variable, and by extension, that race imputation algorithm is performing. And then we wanted to measure, are there any differences in the measured outcomes when we use the RTI race variable that was imputed versus using the self-reported race ethnicity variable. And so I'll show, we used a number of outcomes. So I'll show the kind of 30 and 90-day readmission rates that we collected from the MedPAR files, which is the way that Medicare collects hospitalization outcomes. I'll introduce the surveys kind of quickly. So CAPS, I've referred to quite a number of times. These are surveys that CMS sends out to Medicare beneficiaries, asking them to talk about their experience with healthcare services in different settings. It's required every year. And for this study, we just focused on the survey for Medicare Advantage beneficiaries. And the sampling is about 600 beneficiaries from every managed care contract every year. Similarly, there's another survey called the HOS, the Health Outcomes Survey. This is used to measure functional health outcomes, primarily physical and mental health functioning for the Medicare Advantage program. It's conducted annually every year since 2015, and they had updated questions on race, ethnicity, sex, primary language, and disability status as a result of the ACA. And their sampling is a little bit bigger, about 1,200 beneficiaries from every managed care plan every year. So this is the study population. So we have Medicare beneficiary files from 2015 and 2017, covering about 61 million beneficiaries. Of that set, about a million completed a survey between 2015 and 2017. So there's already a few limitations, right? Our study's requirement on, we're only able to get self-reported race ethnicity from completed surveys. And this is limited to Medicare Advantage beneficiaries, which is a subset of the Medicare program. So before I kind of get into the results, I think it's kind of important to talk about how even in these two surveys, race ethnicity is captured. So there's two questions in the CAP survey that are used to determine your self-reported race ethnicity. So one being, this question, are you of Hispanic or Latino origin or descent? And then the second one being, what is your race? And this is maybe the two types of questions that most folks have seen when you're asked in a survey of what your race and ethnicity is. So either the first one's either yes or no, and the second one is you can select one or more of these race categories. So if you're really good at combinatorics, you'll realize that there's about like 720 possible variations of race, and you multiply that by 2, and that's about 1,440 different possible combinations of self-reported race and ethnicity that a survey respondent could potentially self-report. HOS is actually, it's a little interesting. They went a little bit farther than the CAP survey. So again, 2 questions for self-reported race and ethnicity, but for the first one, rather than a yes or no, you can, if you report yes, then you select one or more of the ethnicity category. So on question 58 on the right. And then the second one for the race group, again, one or more of the race categories, but the Asian category is broken out, and the Native Hawaiian Pacific Islander categories are also broken out in a little more detail. I won't get into the combinatorics here, but obviously a lot more combinations of race and ethnicity that you can self-report in this survey. And so one of the problems with the validation study is that now, even though we have such granular information from the HOS survey, that we had to kind of re-aggregate, unfortunately, these categories back into the groups that Medicare collects them in. So this was how, it was kind of straightforward for some of the categories, white to white, Black African American to Black African American, but the Asian categories had to be kind of aggregated. The Native Hawaiian Pacific Islander categories had to be aggregated, and Hispanic or Latino ethnicity categories had to kind of be aggregated. And then moving it back, recall that there's only 5 categories that Medicare and RTI collects race and ethnicity information from, and they actually do it in a kind of differently. So Medicare defines Hispanic as a race category, or they combine them with the race categories. They similarly aggregate the Asian, Native Hawaiian, and Pacific Islander categories. And here's the other part, which is kind of interesting. They don't allow you to select multiple categories. So this kind of raises questions about how do you interpret even those variables in the Medicare data, right? So does a Medicare race value of Black mean any, like Black and any other kind of combination of race or ethnicity? Or does a Medicare race value of Black mean just non-Hispanic Black only? And then that kind of also raises questions like, what does the other category in the Medicare RTI race variable mean? So there's already this kind of inherent discordance even before going into the predictions about like how Medicare uses the system of classification to collect this data, and how the CAPS and HOS surveys uses a different classification system to collect self-reported race and ethnicity data. And so in this study, we had to do a little bit of mapping, right? So on the left is the 5 plus other 6 categories that are available in the RTI race variable, interpreted as in this way. Then we had to map them to the variables that we were collected in the self-reported surveys. And these were the kind of mappings that we came up with. So non-Hispanic white, Black, non-Hispanic Black African American, then Hispanic any race, non-Hispanic Asian Pacific Islander, non-Hispanic Asian American Indian Alaska Native, and non-Hispanic other. And the reason of doing this is because when we do the validation, we want to limit any misclassification as that due to an inaccurate prediction rather than like an inaccurate categorization. So with that, all that set up, the last thing to kind of set up is that because Medicare assigns beneficiaries to only one of its 5 categories, one approach to evaluate the classification performance of the variables is to treat each category as like a separate binary classification problem. So what does that mean? So let's say RTI variable predicts you to be non-Hispanic white, right? Then then we can kind of map to the surveys whether or not that's true, a true positive from the surveys versus a true negative, and this allows for the calculation of sensitivity, specificity, positive predictive value, false positive rates, etc. So here are the results. I think it's a little bit hard, a lot to kind of look at in terms of numbers, but I'll kind of direct you to 2 things that I think are kind of interesting. One is that the sensitivity for those reporting self-reported Hispanic is still pretty low. It's even kind of lower than kind of the previous validation studies. So only 10% of those who self-report as Hispanic are actually being correctly labeled as Hispanic in the RTI and Medicare data. And then for the American Indian Alaska Natives, that number is even lower. Only 8.3% of those who self-report as American Indian Alaska Natives are being captured correctly in the Medicare data. And so then what does this mean for outcomes? When we look at hospitalization rates, which is kind of an important outcome when it comes to healthcare disparities, right? If you were to compare using the race variable from the Medicare data, the RTI variable, versus the self-reported data, there's actually some differences in how these numbers are reported. We find that actually, if you use the Medicare data, you're underreporting 30-day readmission rates for American Indian Alaska Natives by about 2 percentage points for 30-day, and then similarly for 90-day readmission rates. So this could really change how outcomes are reported if you're stratifying by whether you're using the Medicare data or you're using self-reported survey data. And I think the big part of this, if you look at the ends, the reason I included the ends is that a lot of the self-reported American Indian Alaska Natives are not actually being captured in the Medicare data. So it's kind of strange, right? So the next question is, how are they being classified? They're being classified as white, non-Hispanic white, which is fairly interesting. And there's kind of 59% of them being classified as non-Hispanic white, and 20% being classified as non-Hispanic black, and only 8.34%. So that's the sensitivity. Or only 8% of them are actually being correctly classified as non-Hispanic American Indian Alaska Native. Similarly for the Hispanic self-report, how are they being classified? They're actually 73% of them are actually being classified as non-Hispanic white, which is odd, and that kind of gets the 10% sensitivity we see with for the Hispanic group. And then kind of for those who are classified as other, how are they being classified? How are they being those who self-report? Those who are classified as other, how are they actually self-reporting? So primarily non-Hispanic white, primarily Hispanic white, and they're primarily non-Hispanic Asian. And I think there's another part about this, which is that because the Medicare variable only allows you to select one category, how do those who self-report as multiracial, so for example, those who checked off both white and black, how are they being classified by this RTA variable in the Medicare data? And it turns out that the variable doesn't really know what to do with you, right? Because you don't really fit their classification system. You're 37% of them of folks who are self-reported Hispanic, white, black are being classified white. Similarly, 36% are being classified just non-Hispanic black, 22% being just classified Hispanic any, and this is kind of the same regardless of Hispanic or non-Hispanic, kind of white, black, multiracial self-report. And I guess again, to just kind of hone down this point, I think there's an interesting kind of justification for using Hispanic ethnicity, right? Because if you were to look at not stratified by Hispanic ethnicity, just the reported outcomes for those non-Hispanic white and non-Hispanic self-reported white, you wouldn't see a difference in the outcomes of 30-day or 90-day readmission. You see the numbers are kind of similar. But when you do stratify by self-reported Hispanic ethnicity, then you do see some differences in the reported outcomes, which may signal some interesting reasons for using Hispanic ethnicity as a stratification for these outcomes. Running a little bit low on time, so I'll kind of zoom through some of the rest of the study. There's obviously limitations that we were only able to study the population of folks who actually respond to surveys, and we didn't account for any survey sampling or applied sampling weights. We were limited to Medicare Advantage enrollees. And there's reasons for racial ethnic minority groups are disproportionately enrolled in Medicare Advantage, so this could actually potentially overestimate or underestimate misclassification. If those unwilling to report self-reported race and ethnicity are more likely to be misclassified. And then I think this is the kind of more important, is that in order to do the validation study, I had to kind of spend a lot of time talking to you about what classification system to use in these surveys. So we implicitly have to kind of accept those as the categories of true self-reported race and ethnicity. So like when you're given boxes to check, this is how people self-select into those boxes at face value. And we had to do that in order to align the self-reported race and ethnicity to the Medicare variable. And we don't look at characteristics that might affect why certain folks would check certain boxes rather than others. And I'm trying not to attribute any specific meaning to this classification system, but like if you choose to use this variable in Medicare, we wanted to show you what the limitations of that choice was. I'll zoom through it because I know we want to leave time for questions, but like classification performance is really bad for self-reported Hispanics, American Indian Alaska Natives. This leads to differences in measurements of outcomes, especially for those who self-report as American Indian Alaska Natives, as well as those who self-report multiple races, and that the RTI race code just doesn't handle the classification of multiracial beneficiaries very well. And I do want to maybe I'll just end on this slide, which I think is kind of tying it back to social justice and health. Here in this, we have an example of systematic bias that's introduced by this algorithmic misclassification error, and I think there's fairness implications here, right? Because even it's kind of ironic in trying to impute race and ethnicity, the algorithm disproportionately misclassifies those who are Hispanic and non-Hispanic American Indian Alaska Natives. And then kind of stepping back to I think some of the talks from last week, about choices and systems. The choice of how you want which race and ethnicity categories to choose, and whether or not you can choose one or choose multiple, that has a lot of downstream effects on how we measure outcomes. So in this case, which race and ethnicity categories we choose has impact on the racial disparities that we measure downstream. And as we saw with the multiracial beneficiaries, the algorithm is probably working as intended, but the classification system that it's using or was trained on is just wrong, right? It just doesn't reflect true, self-identified race and ethnicity. I'll skip some of the positive. I mean, obviously, they should assess this variable more often. They should update, their classification system to be more allow for more granular collection of data. And I think I also wanted to know, the census form that I showed in slide 2 was kind of interesting, right? It's actually the first time, the 2020 census was the first time they allowed folks to write in their race and ethnicity and not just check in boxes. And one of the things they found as they've been analyzing the 2020 census is that more and more people are reporting 2 or more races, even regardless of stratification by Hispanic or Latino ethnicity. So if Medicare doesn't kind of change how they categorize race and ethnicity, this is only a problem that's going to continue to happen and grow. And then also this question of like, should we even be using race, right? Whether we should be using a race variable at all is kind of an emerging question for health services research. And in the healthcare research, using race can actually lead to kind of bad outcomes, right? It can give rise to erroneous biological explanations for racial health disparities. It can give explanations grounded in racial stereotypes and behavioral patterns. It can imply that certain social problems are racial and therefore only of concern to those who are interested in minority groups. Using white racial framing, using white as a reference group, and I think the most important part is also that race is just often a proxy for other mechanisms. So there's this quote, are you actually trying to capture racism based on skin color? Are you actually trying to capture differences because of English proficiency, disparate opportunity, or socioeconomic status? And I'll just end on this quote, which I think is kind of been more interesting to talk about in terms of like how healthcare services research has been addressing research around health disparity, which is that if we know that racism is what causes health inequities, then maybe it's better to develop better ways to measure systems inequity and name racism as the central concept, rather than, as you can see from this talk, using these racial categories that maybe aren't the best measures of equity, right? Are they really, is it really worth it to impute race and ethnicity? And to use them as the only way to measure equity in some of the policymaking in the United States. So there's 5 minutes left. I'd love to hear folks' thoughts. Sorry, I kind of rushed through a lot of the results and stuff, but I hope this was sort of useful and hopefully matches the theme of social justice and health for the DSI Fair February talk. So thanks.
Thank you, Andrew. This is an excellent talk. I'll just open the floor to questions from the audience or from Zoom. Check the chat. So I guess there are no other questions. So I'll just go with one that I had. You kind of addressed this, Andrew, towards the end of your talk about whether race is actually, we should be classifying race or not and using it as a measure for outcomes. I was wondering, like, are you looking at sort of like other mechanisms through which disadvantage in health outcomes could manifest itself? Like, are you thinking of race intersected with economic status or something like that?
Yeah, so even I think one secondary question we can do with this data set is that, as I mentioned before, one of the surveys asks about patient experiences with health outcomes. So you're asked, you know, how do you rate your last provider visit? How do you rate like the communication of your provider, stuff like that? So maybe those are the mechanisms through which folks experience worse or better healthcare outcomes rather than using just race only. So, and I think there's another kind of interesting paper that came out recently in Health Affairs, where folks were trying to kind of measure documented race bias in the electronic health record. So are there ways to measure how folks are being explicitly discriminated against in even just the EHR by providers? Those might be creative approaches to measuring racism rather than just relying on these race and ethnicity categories that we do maybe a little too often by itself.
Got it. Okay. Are there any other questions from the audience? Okay, then I think we can close the session. Thank you so much, Andrew. This is a very informative talk, and this will be up on YouTube, and hopefully people can reach out to you with questions at a later point.
Absolutely, please do.
Thank you so much.